So today we're going to be talking about stigma, from stigma to safe use and services, and addressing the overdose crisis. I do apologize. I know we were supposed to do the CBT training today, but after our educational coordinator was going through the slides, she saw some things that we needed to modify and change before we did the presentation. So I thought this would be a good opportunity to talk about stigma, since that's something that all of us in the field encounter pretty regularly, I think. So what I hope to do today is just for us to kind of just have a conversation, hit on some points about it, learn some things about how it came about historically, and also some ways that we can appropriately address it as we encounter it in trying to provide services for our clients. So let's look at some of the learning objectives we'll be talking about today, right? So first, we're going to outline the history and the impact of race and stigmatization on substance use disorders and their treatment. We're also going to discuss similarities of the chronic illness model for hypertension, diabetes, and substance use disorders. Just because they are all kind of interrelated, and we can use harm reduction methodology to address all three. But because of the stigma attached to substance use disorder, hypertension and diabetes is much more acceptable than the utilization of these processes when it comes to people that have substance use disorder. And the third one is to practice the use of non-stigmatizing language and the understanding of care planning for people with substance use. I think that language and semantics is a big deal. It goes a long way toward, I think, the destigmatization of our service provision, as well as kind of closing that void that we see that happens, that occurs when people use stigmatizing language when addressing our clients that have substance use disorder. So let's start off with a working definition of what stigma is. Sampson defines stigma as stigma is defined as a mark of disgrace or infamy, a stain of reproach as on one's reputation. Stigma remains the biggest barrier to substance use treatment faced by patients and clients. I agree with that. One of the things that we encounter, one of the biggest issues that we encounter in community outreach when we're in the community and we're talking to people, is a lot of the myths that come along with trying to provide services for people. Handing out Narcan, for instance. Sometimes people are under the impression that Narcan is a narcotic that they can get in trouble for having on their person. We're trying to give it away for free. We tell them that it's the overdose reversal medication. There's no law against you having it. There's no law against you using it. We talk to them about the Good Samaritan law and all of those things, but we still run across a large amount of apprehension just because of the stigmatization of people having drugs on them or having the means to be able to help people. So taking that definition, we want to talk about the different types of stigma right here. Can everybody see that? Because I know it's kind of small on my screen. I can't hear you, Ms. Glory.
Sorry, it's a little small.
Let me see if I can.
If you go into presentation mode, you can probably change that.
Okay, now how do I do that?
The bottom of the screen, the little icon that's next to what looks like an open book.
Okay. That one.
Yes, there you go.
Wow. Thank you, Ms. Gloria.
So
that's better.
Yes.
Okay. So there are three types. I'm sorry. Now, how do I go back? Okay. So there's actually three types there's 7 types of stigma, but they're in 3 different categories: patient-related, system-related, and provider-related. I'll ask for a little help in regards to reading some of these when we talk about it. So we can start with systems related. If somebody doesn't mind reading this type 1.
I got you. Type 1. Public stigma. This happens when the public endorses negative stereotypes and prejudices, resulting in discrimination against people with mental health conditions.
Okay. I want to preface this by saying that the stigma that we're talking about right now, the stigmas and the examples that we're going to see right now are related to mental health conditions. Later, we're going to see the intersectionality between mental health conditions and substance use disorder, and how the two are mirrored in regards to how the stigma is presented from provider to client and from systems. I read number 2, which is patient related. Patient related type 2 is self-stigma. Self-stigma happens with a person with mental illness or substance use disorder internalizes public stigma. Okay. I'll read number 3 as well. Number 3 is patient related as well. It's perceived stigma. Perceived stigma is the belief that others have negative beliefs about people with mental illness. So when we start looking at the different types of stigma, and we look at how it affects a person or a patient personally, a lot of times that they when they come into services, they kind of come in with, for lack of a better term, they come in with that kind of baggage already, just because of their exposure to interactions with people in their community, people in their families. All of that helps with their image of themselves and how they're perceived in regards to trying to get services. The third one in the patient-related category is label avoidance. And this is when a person chooses not to seek mental health at all, and to just avoid being assigned a label of being, one of the outdated terms is an addict, or someone who is an addict, the negative connotative words, addict, junkie, things of those nature. So sometimes the perception of self, the need to avoid labels per se, that all keeps them from being able to go into a system or to a provider to seek help. So largely that, and it falls upon us as service providers to try to eliminate some of those obstacles that those people who are seeking help come into services, then they already have those intact. So when we talk about our systems related one, we talked about that already. Danny read public stigma from a systems related standpoint, where different stereotypes and things like that are attributed to people with mental health. Type 5 is stigma by association. So stigma by association occurs when the effects of stigma are extended to someone linked to a person with substance use difficulties. This type of stigma is also known as courtesy stigma or associative stigma. So it can be transferred off to families. It can be transferred over to friends who know or associate themselves with the person who may be suffering from the disorder, whether it be mental health or substance abuse. Sometimes by association, you're kind of grouped in with them. The last one in systems related stigma is structural stigma, which is institutional policies or other societal structures that result in decreased opportunities for people with mental illness and are considered structural stigma. So because of your particular illness or the particular disease that you're dealing with, you can also be ostracized from being able to get services. Certain institutions won't even address your particular won't even address what your ailment is because of the stigma that's associated with it. So the last one is provider related, and that is health practitioner stigma. This takes place anytime a health professional allows stereotypes and prejudices about mental illness to negatively affect a patient's care. We've probably all heard stories about that. We know about the inequities in healthcare. We know about the inequities in services and community resources, and how they're attributed. So when we look at those three things, and we come from us as service providers, we know that we're gonna probably encounter maybe one or maybe all three of these when we're trying to provide services, and being familiar with them, being familiar with what they look like, will help us to be able to kind of comprehensively come together to look at ways to either combat that or resolve it all together. Skip this. Okay. All right. This particular slide here talks about some of the myths and stigmas that are attributed to substance use disorder. Now, on the right side, we have what are the necessary. I'm sorry, the left side. I'm confused. The left side is the stigma. On the right side are the myths that are associated with that. So lots of times we encounter other people in our communities, other entities that are that we're trying to get to come into the supportive circle of service provision. And what we meet up with is what their opinions are of people who use who have substance use disorder. And one of the first things that we hear is that it's a choice, that people choose to suffer from this particular disease. One of the myths that is attributed to it, I apologize. One of the myths that's attributed to it is that it's easy to get treatment. That people can easily come into just go in somewhere and receive treatment, and in about 30 days they'll be okay. Or if you watch television, and in the midst of an hour, a person can literally go from being addicted to being all the way okay. The other thing is that they say that they don't really want help. Just because a lot of people suffering from substance use disorder initially are not receptive to resources that are presented to them, just because they've probably had experiences where they've experienced some of the structural or systemic stigma that we talked about previously, and also provider stigma. The other thing is that from a lot of times there's judgment that comes from the faith-based community, that it's a moral failing, and that's something that it's a sin, and that they're committing some kind of it's a moral kind of judgment that they have, or a moral decision that they're making to use substances. So the myth that's associated with that is that they can just stop at any time, and that they can just utilize willpower, and that it'll be done. The other thing is that they look at and categorize and stereotype substance use disorder as people that are just bad people. One of the myths that's associated with that is if they didn't want to live like that, they wouldn't. And again, here's some of the negative stereotypes and tags that are put on substance use disorder clients, that they're just junkies. The other thing is that they tend to think that if you're an opioid use disorder, that you can't have pain. When in large part, a lot of our clients that have become or have succumbed to substance use disorder are basically people who have had chronic pain and are using prescription medications and have just been overcome with the pain and have become addicted. The other one is Darwinism and the survival of the fittest. That comes from a purely racist standpoint in regards to most of the stereotypes that we hear today are that Black and brown people are the majority of the people who are suffering from substance use disorder, and that it's something that is a weakness for them genetically. The other thing is that medicated assisted treatment enables substance use disorder. So we run across a lot of that mythology when it comes to talking to people about having MAT treatment and things like that available for people who are incarcerated. Sometimes there's we run across that when we encounter young women who are pregnant and have substance use issues and things of that nature. I just recently heard this one. It can never happen to me. We were doing a Narcan distribution in Rogers Park at the Rogers Park Library, and we were doing our presentation, and it was a woman actually came up to our table and asked us what we were doing. We explained what Narcan was and everything like that. She literally said that it couldn't happen to her. She's never ever been involved with drugs, and so we basically tried to let her know that what we're trying to do, we're trying to just educate the community about people who do use it, and have us come together to be able to try to provide those services as a community. She wasn't buying it, and she also thought that harm reduction methods were a way of enabling, just like this last one says that Narcan enables substance use. Why revive them? They'll just use again. So that's actually a quote from the former governor of Maine, but it's something that we hear a lot of when we are working in the communities and we're looking at trying to educate them in regards to harm reduction methods as well as Narcan provision. Okay. Here are some facts in regards to substance use disorder. Substance use disorder is among the most stigmatized conditions in the US and around the world. Healthcare providers might treat patients and/or clients with substance use disorders differently due to stigma. People with a substance use disorder who expect or experience stigma have poorer health outcomes. According to the World Health Organization, about 75% of health inequities or differences in outcomes could be considered unfair and potentially avoidable, and as a result are labeled health inequities. So statistically, we can look at how stigma, number one, provides a huge barrier in healthcare to people who are coming to seek help in some of our emergency rooms, and some of our community-based resources that are providing substance use disorder treatment. And according to the World Health Organization, about 75% of the health inequities that we see amongst people are basically coming from these types of stigma, and that those kind of inequities are helping to elevate the number of people who are suffering from substance use disorder and are not receiving treatment. So as we talked about in our learning objectives, we want to talk about where things where things started from a historical perspective. In the late 1800s, in the early from the late 1800s to the early 1900s, you could get pain medication, narcotics, things like that. They were in everyday over-the-counter medications. They were provided in pharmacies and drugstores across the entire country, and it didn't matter if you were Black, white, Latino, Asian. You could buy remedies and things of that nature from everything from drugstores to traveling carnivals and things of that nature. You can see here in the picture that cough syrups and toothache drops and all of those things contained what we now look at as illicit narcotics. Coca-Cola, although I mean that's one of the more familiar ones. We look at the cough syrup, and I'm looking at all the different ingredients in cough syrup, and I'm saying, wow, that could probably put you down. Alcohol, cannabis, chloroform, a form of morphine. So all of those things in the early, I'd say the 1800s to the early 1900s up to around 1910 were all easily accessible by everybody, and were widely used for whether it was pregnant mothers or children. These were all remedies that were used in regards to addressing some of the everyday ailments we would have, such as toothaches or coughing or a cold or headaches or things of that nature. Okay. The only thing about the presentation part, Miss Gloria, is that when I do this, I'm not able to see my notes.
Oh, okay, I see.
So let me see if I can.
You can always exit the presentation.
How would I do that?
You can just press escape.
Okay. All right.
Mhm.
This isn't horrible though? Can you guys still kind of see it?
I
I
can
realize
see
it's
it.
smaller. Okay.
Yeah, I can see it.
All right. The from the previous slide, I wanted to go back just for a quick second. As you move into the early 1900s, the government and the community at large became really aware that these remedies were popular. The remedies that we're talking about, cough syrup, toothache drops, and things like that. Those things were popular in the Black and other communities of color. The government and the white communities became very concerned about that. They started spreading a lot of propaganda in regards to how these remedies were affecting people of color, Blacks and other people of color, and saying that using these remedies, it started to make them become. They start to use it as a form of intoxicants and using it for recreational purposes, and subsequently being out of control, going as far as to state that using these particular remedies made people become violent, especially Black people. It made them become violent and been violent, aggressive, and then they would say stuff like they would become rapists and things of that nature. So as the propaganda was spread, it was not only spread through newspapers and within the medical profession, but also through at the time the newest form of media, which was motion pictures. One of the most popular propaganda movies was a movie called Birth of a Nation. It was a silent movie that was made in 1915, but it depicted Black people in the post-Civil War as being drug addicts, rapists, insurrectionists, all of that. And it didn't actually have any Black people in it. It was an all white cast, but it was people in blackface who were actually trying to depict the community as being very violent, very aggressive, and actually pretty dumb because of some of the captions used there use a lot of derogatory and negative dialects and things like that. But the other thing that happened from this movie was that it galvanized the racialization of legal drugs and narcotics. And as you can see from the caption here, political legislation was created starting in 1914 that threatened the prosecution of doctors and pharmacists who treated people with chronic pain or substance use. And it actually, in the Supreme Court from 1919 to 1920, started the beginning of criminalization of using prescription medication rather than treating people with chronic pain or people who even had substance use disorder. We also see that 2,500 physicians from 1919 to 1935 were indicted under the Harrison Act for violations. All morphine maintenance clinics were closed, and then medical treatment for opioid use disorders and things like that, they just disappeared. So I'm sorry, I gotta go back. Struggling here. So what we saw at that point after that was after 1920, we saw a huge void in regards to services and what the Black community and other communities of color could do in regards to getting help for any kind of addiction disorder or things like that, or just getting pain medication. So we started looking at how things were stigmatized. As you can see here again, in the 1930s, movies and propaganda films were still very popular. This time it's marijuana and it's aimed for the Latino community, and saying that once they started using medical marijuana, because they were using medical marijuana for medical and medicinal purposes even in the 1930s. But as the previous legislation that we talked about started to come in and be made into law, addiction was no longer the domain of medical or public health officials. Now it fell totally under the realm of criminal justice. So if you were caught providing services or caught treating anyone with any kind of like medications that contained any kind of opioids, you were charged criminally. And at this point, the faith-based communities became very, very prominent in that movement. And we saw that the message was about that addiction was a moral failing or a lack of willpower, and that heroin addicts were the spawn of sin and crime. This left a huge vacuum in services from 1920 all the way up until 1970. So in the interim, we saw the growth of mutual aid societies such as AA, a lot of other 12-step programs. They even came up with things called narcotic farms that used a lot of archaic methods of trying to treat people, like electric shock and psychosurgery, aversion therapy, as well as sterilization. So the only time they used medication was strictly for detox, nothing to manage pain or anything like that. And so we're looking at some pretty dark times all the way up until 1970. In 1974, we saw the Narcotic Addict Treatment Act, which again kind of moved us back toward medication assisted treatment in regards to provide methadone maintenance treatment, established an association to study the medical disease of substance use disorder, and allowed doctors to again start prescribing medications. The medical community progressed. We kind of saw it parallel moving forward in regards to the same way that we saw things happening with the civil rights movement, although it was short-lived because during the Reagan administration, we saw the quote-unquote war on drugs again criminalize a lot of well, actually what it did was it conflated a lot of what we saw as drug treatment be confused with drug sales and things like that. And a lot of people, a lot of times people of color and Black people started going back to jail for use of those drugs as a means of we saw a lot of people who are using drugs because of the socioeconomic issues. they became addicted, and then subsequently they were sent to jail. So we saw that was a huge issue for the war on drugs. In 2002, we saw that buprenorphine and Suboxone was the first medication approved by the FDA for opioid use disorder. And in 2006 to 2010, the FDA approved injectable naltrexone for alcohol use disorder and then opioid use disorder. So that was the precursor for our Narcan in regards to it being injectable. One of our more recent legislative moves was the 2016 Comprehensive Addiction and Recovery Act that allowed doctors to prescribe medications for opioid use disorder. Most recently, we saw that the Biden administration reversed one of the Justice Department's positions on overdose prevention sites. I don't know if you guys recall it, but at the time when the legislation came about, there was a lot of pushback in regards to what the overdose prevention sites would look like and what they would be actually doing. A lot of it was focused on needle exchanges and talk of us enabling people who were suffering from substance use disorder and things of that nature. So we've seen a couple of different pandemics. We've seen mental health pandemic. We've seen the opioid pandemic, which right now we're kind of still in the midst of. The last numbers we got were from 2021, where we lost 100,000 people from overdose. And we just come out of the COVID pandemic, I don't know if we're all the way out of it, but some of the restrictions have been kind of lessened and reduced in that regard. So we look at that, and as we're coming out of that, we still see that opioids are severely affecting our communities. We're still trying to educate the community on ways to help those of us who are suffering from substance use disorder, distributing Narcan, talking about harm reduction methods, but we still see that there's a need for progress in medical care in regards to how we're treated from a systemic standpoint, from a provider standpoint, and for those people who are in charge of the care of people with substance use disorder. So the substance use disorder modern chronic disease model is one that looks at 3 chronic diseases, basically. We look at hypertension, we look at asthma, and we look at drug addiction. And we look at the lifelong goals of all 3 of those. One lifelong goal is the lifelong management. So as we look at the graph here, we see that the other 2 have a more increased more increased potential for relapse. We're right at 60% when it comes to drug addiction. As far as hypertension and asthma, those are chronic diseases that we can take medication for and make some dietary changes and behavioral changes, and there's a higher potential for us to relapse from those particular chronic diseases than from drug addiction if we make those same kind of changes and things like that. So we look at the bullets and we look at the disease severity may change over time, but the risk and symptom of recurring is present with all 3. We also looked at effective treatment often combines medication, counseling, and peer and recovery supports. Those are things that are usually associated closely with drug addiction. But there are support groups. There are peer recovery groups for both hypertension and asthma because both can be very severe. I don't know about you guys, but I know people who have actually died from high blood pressure and the other comorbidities that come along with it, as well as asthma, because it's largely goes untreated, or it can also be confused with seasonal allergies and things of that nature. So we see that of the three, and we can look and we can refer back to the stigma that's associated with drug addiction. That of the three, I think that when I first saw this, I was a bit surprised at the percentage of relapse being so decidedly different with drug addiction as opposed to hypertension and asthma. So we talked about the definition of stigma. We've talked about some of the historical ramifications that we've seen, how stigma has evolved over the last 100 years or so. And now we can look at substance use disorder and look at the current definition for it. It's defined as a complex chronic disease of brain reward, motivation, memory, and related circuitry. A chronic relapsing disease characterized by compulsive drug seeking and use, despite harmful consequences, as well as changes in the brain. The DSM talks about it as being a brain disease whose symptoms are overwhelming cravings and resultant behaviors. So, one of the things that they talk about in the different substance use journals that we utilize to compile information is that eventually they'll come up with a vaccine to prevent dependence and tolerance to drugs. I'm not sure how close we are to that, but in the interim, what's left is us as service providers providing a level of comfort, a culture of acceptance, and ways to be able to work with the client comprehensively to be able to deal with and live with this chronic disease. So when we look at why some people develop an SUD and others don't, there's actually two contributing factors here. And it talks about the biology and the genetics of it. And it also talks about the actual environment that a person lives in. I may have to go back to the presentation part for this, Ms. Gloria, because I can't see that at all. All right, so we talk about the two, from a biological and genetic standpoint. There's genetics, there's gender, and there's mental disorders. Conversely, we talk about environment. Sometimes those two things work together, and the way that we see it culminate is in addiction. Sometimes when we talk about the environment, we're talking about circumstances at home being chaotic, instances of abuse. There may be parental or familial use of drugs, and an attitude toward that. There's always peer influences. Sometimes the company we keep, our friends and things like that, peer pressure are all contributing factors to people experimenting, young people especially experimenting. The other thing is that we look at community attitudes. Sometimes in some of our communities, drugs are accepted. They're an accepted way of coping. It's an accepted way of dealing with problems and issues. And also, and probably one of the things that has been a bit underscored here is low academic achievement. And unfortunately, that's something that's indicative of a lot of our communities of color. Our educational institutions and educational programs are a lot of times lagging behind the white communities and the more affluent communities that we see in our different cities. And those can be largely very, very large and very big contributing factors to the use of drugs and how we allow that to be affect our lives. So we look at drugs and we look at the different brain mechanisms that bring us to addiction. So when we look at addiction and we talk about how the brain basically processes that, the caption to the right basically looks at the different kind of cravings that our body has, and how our brain processes it, and how it, and in size, how those three things, how the disparity when we look at the craving for food is the size of a baseball. And I guess this is supposed to be symbolic of in size of what the craving is for food. So it's as small as a baseball. The craving for water when we're thirsty is the size of a basketball. But in contrast, the craving for drugs when you are someone who is suffering from substance use disorder can be as large as a baseball field. So when we look at that and we look at it in contrast of being hungry and being thirsty, we see that the craving for drugs is enormously much larger in size, and consequently requires a much larger effort and a bigger community effort from all of those who are supporting people who are suffering from this disorder to be able to combat it. Let's see, go to the next one. All right. So let's see where we at in regards to time. Okay. So here are the social determinants of health. And even though we're looking at it from the standpoint of someone with substance use disorder, these are these 5 areas are things that that affect all of our everyday lives. When we look at where we are from a healthcare standpoint and where we are as far as accessibility, fortunately, we healthcare, because we work and we have jobs and things of that nature, the accessibility to it is pretty high. It's pretty easily accessible. But for people that are suffering from substance use disorder, don't have economic stability, have issues with housing and places where they live, and don't have not, as we talked about earlier, may not have the highest level of education and access to education, as well as having a social circle that may be tolerant or accepting of the drug culture. Those present huge obstacles in regards to being able to combat being someone who's suffering from this disorder. The conditions, and the caption says, social determinants of health is defined as the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life. And as I alluded to earlier, that tends to speak to all of us, all of our growing up experiences, that although they may be different, they all encompass all of those 5 things. When you look at that, and it's compounded and made that much more difficult if you have substance use disorder. So we look at the 2 sides of the coin here in regards to these four particular paradigms. From an individual standpoint, we see that in most individuals, we see a decrease in prescribers in low-income areas, and a decrease in access to Suboxone. What we want to see on the flip side of that is that we provide people with a personal knowledge of harm reduction. We want to see them be able to understand that there are other options to treatment. Abstinence is not the only option. And then harm reduction, if treated just like a chronic disease, and we use the chronic disease model, is something that could be manageable. The interpersonal approach. A lot of times we from the community at large and our family members, we received the whole tough love approach. And, you know, this is something you can beat it, you can kick it or what on your own or whatever. But again, on the flip side of that, naloxone education and being able to carry something with you that will help you, that can actually save your life and give you a second chance at being able to seek treatment and to move forward. In the community, the NIMBY approach is something that is an acronym for not in my backyard. And basically what we find when we go into different communities and try to educate them on the different facilities that we want to set up there and things like that, they're absolutely confrontational and aversive to that. They don't want substance use facilities in their areas. They don't want shelters. They don't want recovery housing or anything like that, because they feel like bringing that element into and bringing those services into that community will bring a negative element into the community, bring down property values and things of that nature. We also see that in rural communities, there's a huge decline in regards to substance use disorder. There's a denial that there's even a need for it there. So that's one of the things that when we look at outreach, it's also not something that's just going to be confined to within city limits. It has to be done. Methamphetamines and things like that run rampant in the rural communities, and we have to pay attention to that and be able to provide outreach that's tailored to those communities as well. From a societal standpoint, we want to try to make sure that we have overdose prevention sites, and not sites that are going to be eyesores to the community or things like that, but just sites that are going to be inviting and provide a comfortable culture that promotes healing and promotes helpfulness for a person to feel comfortable that they can come in and get help if they're suffering from SUD. And we talked a little bit earlier about the bill preventing harm reduction in Congress. We've seen a lot of conservative opposition to harm reduction, needle exchanges, and things like that. But in retrospect, we saw the same kind of pushback with contraception, condoms in schools, and things like that. So we're hoping that statistically that we can look at some of these numbers, and Congress will move forward in regards to being able to provide federal help and federal funding, and continue to be able to move forward with the harm reduction methods that we've been trying to utilize, such as Narcan and the overdose prevention sites. This is the question now. Let me see where we are. Actually, if you don't mind, Ms. Gloria, I want to get to the last part, is actually the language part, and I think that's a very, very important part of this presentation.
Okay.
We talk a lot about how we engage our client population, and it's important that we look at moving forward with having positive and progressive language, and not fall back into a lot of the language that was used in the propaganda films that we talked about earlier, and in the treatment that we talked about earlier as well. So when we talk to somebody about having substance use disorder, we want to address it as a disease and not a drug habit. When a person is moving into recovery and in recovery, we don't want to call them an ex-addict. We don't want to describe them as being clean, because we don't want to look at the addict as being, if they're suffering or they suffer a relapse, we don't want to look at them as being dirty. So what some of the semantics that we're talking about here is that the person is just living in recovery. They're not an ex-addict. They're not clean. They're living in recovery. So if a person happens to be arrested for a drug violation, they're just that. They're a person arrested for a drug violation. They're not a drug offender. They're them having drugs on their person is not an offense to anyone. It's something that's detrimental to themselves, but we want to try to move away from that, the negative connotative kind of semantics. A urine drop, it's either negative or positive. It's not dirty. It's not a dirty drop. A lot of those connotations that we use, or that we hear being used, are all things that make it that much harder for people to come into services. Methadone and Suboxone are the drugs that are used to help people in recovery. It's not replacement. It's not a crutch. It's not enabling them or anything like that. It is merely just a drug that we use the same as we would use, the same as we would use insulin for diabetes. So, lastly, we want to look at some examples of harm reduction. So, the defining features of harm reduction include a focus on just the prevention of harm. It doesn't have to be something that is used specifically for substance use disorder. If a person is having sunburn, the harm reduction methodology we would use there would be to apply sunscreen. If a person is we want to reduce harm in car accidents and speeding, we reduce the speed limits and we provide seat belts. Contraception is a form of harm reduction, as well as filters for smoking. All of those are methods of harm reduction. I think that when we talk about harm reduction, there's a huge stigma that's attached to substance use disorder, where we think of harm reduction methods only being about needle exchange, the overdose prevention centers being places where people from substance use disorder, or who have suffered from relapse or something, that they're there and they're going to bring a criminal element. All of those are myths that go a long way toward promoting the stigma that prevents people who are suffering from the disorder from being able to actively seek help. So, in conclusion, we want to make sure that we know the facts about substance use disorder and consider it a disease, that there is treatment and recovery possible. We want to be aware of implicit bias as service providers, and from a systemic standpoint, we want to make sure that we choose our words carefully and avoid hurtful labels. Want to be kind in regards to being able to provide these services for people. We definitely want to be able to educate people. We want to be able to talk to people about being able to administer Narcan and to look at what the symptoms of overdose look like in a person that's suffering from substance use disorder. We want to be inclusive and supportive. Also, we want to replace negative attitudes with evidence-based facts. Offer compassionate support, and lastly, treat people with substance use disorder with dignity and respect. So I think if my takeaway when we were putting this together was I totally can appreciate the historical aspects of the presentation. Definitely it gives you some ideas and background of where things came from, how they've evolved. But I think for me, the biggest takeaway, and I'm not sure how you guys feel about it, but the biggest takeaway for me was just the emphasis on language. I grew up around people who use that kind of language when talking about people that have substance use disorder, calling them addicts, people who are on probation, being saying that if they had a drop that was positive, that it was dirty and things like that. So for me, one of the challenges that I encountered was just trying to overcome the language part of it and being conscious of it when I'm talking to people who are suffering from this disease, and looking at it as a disease and not some kind of moral failing or someone who's just a sinful or bad person. So hopefully the presentation was able to shed a little light on that, provoke some thought, and eventually help us to be able to be better service providers in regards to our level of empathy for people who suffer from substance use disorder. So that concludes the presentation.